Welcome. Thank you for joining for this important discussion on health equity and access to patient care. How can low-income patients and underserved populations get access to the health care they need? What barriers to health equity need to be addressed and reformed? And how do we move to a place where all Americans can afford the cost of prescription drugs? We will be joined this morning by a member of Congress and health experts who will shed light on this important issue. I'd like to thank the AIR 340B, the Alliance for Integrity and Reform, for their support of today's conversation. A few housekeeping notes before we get started. Please keep your phones on silent for the duration of the program. And we do encourage you to join the conversation on social media. You can follow us on Facebook, Twitter, and Instagram at The Hill Events, and we'll be using the hashtag #TheHillHealth. We will be sending out an electronic survey after the event. We'd love your feedback. Please let us know how we can do better. And with that, it is now my pleasure to welcome our first guest this morning. Congressman Michael Burgess is a physician and represents Texas' 26th District. He has served in Congress since 2003. He serves on the Energy and Commerce Committee, Rules and Budget Committees. He is also chair of the GOP Doctors Caucus. Please welcome Congressman Burgess. Hey, thanks,
Bob.
Congressman. Okay, so we have some pending legislation in Congress. The House is trying to get out for the August recess. What do you see for the rest of the agenda? We've seen the Democrats' Build Back Better program kind of dwindle. Do you think anything will pass before the midterms?
Well, the short answer to your question is yes. There are things that will pass. We'll name a ton of post offices. I'm sure there's some gold medals that have yet to be awarded.
That kind of stuff.
Build Back Better, I was not a big fan last October when it was in the House. You know the twists and turns that have happened. I guess the drug pricing portion of that is capturing some measure of attention right now.
Right.
It's hard to tell where, and again, this is all, as a House Republican, I'm in the minority and in the body that is actually not now working on this, so it's a little tough. But from what I see across the rotunda, seems like Senator Manchin is calling a lot of the shots right now, and we are all interested in where he is eventually going to come down. But look, having been at this for a few years, the 340B program, designed to help people who were in the toughest possible space and with the toughest possible conditions. And Congress, in its wisdom, created this program, and it seems to be working absolutely counter to what the intention was. And could we fix that? Should we fix that? The answer for me is a resounding yes. Look, full disclosure, I did residency at Parkland Hospital, so every time I talk about 340B program, I will get a call from Dr. Cerise who says, don't hurt the 340B program, we depend on it. And I know you do. The program, as it is being implemented by large public hospitals like Parkland Hospital, that is exactly what it was intended to do. But why in the world they decided to go down the contract pharmacy route in 2009, 2010, is anybody's guess, but it's kind of like it's counterintuitive. Instead of a Robin Hood where you're going to rob from the rich and give to the poor, we're robbing from the poor and giving to the rich. So it doesn't make any sense. We did have some opportunities in the 2 Congresses ago when I was Health Subcommittee Chair. We did have some opportunities. Our Oversight and Investigations Subcommittee and Energy and Commerce did do a really detailed report on the 340B program. Really highlighted some of the difficulties and where the system was falling short. It was a little more difficult than we got to the Legislative Committee, the Health Subcommittee, because there were a lot of conflicting influences. And then if you remember at the time, I think the Trump administration came up with a rule that had upset some people. That ended up in the courts. Yep. And further sort of clouded the issue. But what we do know is HRSA has the responsibility for oversight of this program. They are not doing that. They need to do that. The contract sites that seemed like perhaps a good idea at the time really seemed to be augmenting the bottom line of hospitals that were already doing very well and not helping the very people that initially Congress had intended to help. My idea that I pushed when the Democrats were doing their H.R. 3 bill several years ago is why not, in the 340B program, why not have the money follow the patient? And so I introduced that as an amendment when we marked up H.R. 3 in October of 2019. It's a standalone bill that I will, again, introduce this Congress. And in the next Congress, if you read the tea leaves properly, there's perhaps the possibility that there will be a different sort of mindset occupying the leadership positions in Congress. And it would be my hope that we could get some common sense reform, like a money follows the patient bill, at least heard in committee, if not passed and signed into law.
You mentioned the midterm. I did want to ask about that. House Republicans are planning to release an agenda later this year. Senate Republicans are not going to do that. When will we see that agenda, and what will be on the health care side of it?
Well, on the healthcare side, it's, look, these next 2 years in the next Congress, Republicans may well be in leadership in the House. Senate, I guess, is still an open question. Don't tell anyone I said that. And the White House is still going to be a Democratic White House. There's no question about that. So most of the effort that you're going to see in the next 2 years, and I don't want to get ahead of the leadership on the committee or ahead of the leadership in the Republican conference, but let's focus on fixing some of the things that need to be fixed, that desperately need to be fixed. 340B is one of those things that desperately needs to be fixed. So rather than a broad switch to consumer-directed health care, for example, which in the past I've supported, look, let's fix some of the things that we can fix where there's broad agreement. And I think in the next Congress, and again, I don't want to speak for the committee leadership because that's obviously not me. I don't want to speak for the conference leadership because that's obviously not me. But my goal would be to, again, let's fix some of these problems that we all know need fixing. We knew going into the Congress in 2017, 2018 that people in the Affordable Care Act simply couldn't afford the premiums because of the subsidy cliff that occurred after you got to 400% of federal poverty limits, no subsidy coming your way because of the phenomenon now known as silver loading, where the premiums are jacked up by the insurance companies for the silver plan because that's where their money is derived from. And the consequence was that a middle-class family who earned over $96,000 a year, in my district, that's a teacher and a policeman with 2 kids, they couldn't afford their Affordable Care Act premiums. There were a number of things that were proposed to help deal with that. It obviously got distracted by all of the other political drama of the day, but that problem still needs to be tackled. Now, the Biden administration with the American Rescue Plan, you remember the American Rescue Plan, that's what provided you an inflationary level of 9%. But the American Rescue Plan increased the subsidy significantly so that families earning $250,000 a year now are included in the subsidy window. Probably a little too generous. That program expires December 31st of this year. So before the next Congress takes the reins, that's something that's going to have to be dealt with. That's a problem that exists it exists for middle-class people who, through no fault of their own, are going to find themselves in this. Republicans and Democrats ought to have some interest in trying to get this problem solved. Arguably, the Democrats say we did what was required of us. We increased the subsidy significantly, but the problem is you can increase it so significantly you can't afford it, and you can only pay for 2 years. Now we're out beyond that. What could we do that is both innovative and respectful of the position that people are in, that would allow us to deal with this problem going forward? Those are the kinds of things we're going to have to talk about.
And as you alluded, it is likely that the House will flip, looking at history, looking at the president's polls numbers, and independent handicappers have it just under 90%. So if that if and when the House does flip, do you think that the president is going to work with the new House majority on healthcare? I mean, there have been some bipartisan bills over the years. I mean, I know there's been the Obamacare wars, and those probably will continue to some degree. But we've had right to try. We've had 21st Century
Great bill, by the way. Just but as an aside, when the FDA was reauthorized the last time on time, and no one got their pink slips at the FDA, who was in charge then? Well. Yeah, right to try was a great addition to the FDA bill in 2017.
And something that the former president still talks about. So do you think that there's hope for healthcare bipartisanship next year?
Well, there always is. Look, for whatever reason, this administration has not been really hasn't reached out. Now, it's not that I haven't reached out. I'm a prolific letter writer and write a lot of letters to
do they get back to you?
Cabinet secretaries and to committee chairs. No, is the answer. And in fact,
that could change next year.
Here's one of our problems, and this is aside from the healthcare space and aside from 340B space. But we don't appropriate any longer the way we used to when I first got here. And an appropriation, we would, the summertime, remember open rules on appropriations bills, and they'd all come up, and every cabinet secretary would have an interest in their appropriations bill getting passed. That doesn't happen anymore. We do some omnibus bills, and then a CR at the end of the year, and then maybe another omnibus, so that we have essentially removed ourselves as the average member of Congress from anything that would impact the intellect of a cabinet secretary. They simply don't need to think about us. One of the great problems that I think we should try to fix is let's try to establish that part of regular order where the appropriations are done in an orderly fashion. Every cabinet secretary, of course, comes before the Appropriations Committee, comes before the Authorizing Committee. That doesn't happen anymore. And as a consequence, when I write to a cabinet secretary and say, this is wrong and you need to be fixing this, right now they're not compelled to get back to me. Took me about 18 months into the new administration to get a call back from some cabinet secretary, and it just shouldn't be that way.
Mm-hmm. As far as you're a doctor, where are we and where are we going with this pandemic, COVID-19?
It's over.
And what have we learned? Well, we're back in person, finally. This is our second event. So things have changed, but obviously it's still here, and the president has it, and Schumer's gotten Pelosi. A lot of people got it.
So obviously it's a different equation than it was two and a half years ago when this all started. And we all lived through it. It's pretty frightening in the early days where you didn't know how it was going to turn out. We can argue about the decisions were made in both administrations, rightly or wrongly, but we've ended up in a place where it's not the it's not the scourge that it was in January, or I guess February, March of 2020, when everything really came to a halt in this town. So we've at least reached a point where we are dealing with it. I know, people will still have controversies on vaccines. Are they helping? Are they not? I think they are. I'm in interest of full disclosure, not violating HIPAA for myself. Double vaxxed, double boosted. I wouldn't have it any other way. There are other antivirals that have come along and
have you gotten the disease? Because about a quarter of Congress has.
Well, the short answer to your question is yes. I had a positive test, but I wasn't sick.
Oh, interesting. Okay.
So over Christmas, when the president told us all to get tested, my wife said we had to test before we went to visit our kids, so I did, and we were both positive. I used it as an excuse to sit in the recliner for a full day and whine, but really I wasn't ill,
right.
And nor was she, fortunately, which was vastly different from what it would have been December a year prior. So. And I'll tell you another thing that is just extremely uncomfortable was the just completely ignoring what natural immunity meant to a person. Mm-hmm. People who had the illness and recovered were discounted from if there was a vaccine mandate, which the president pushed, they could still lose their job, even though they might have demonstrable circulating antibody or T-cell antibody in their system. And I know this because when we were running out of monoclonal antibody in March of 2021, and in Texas in particular, and Doctors Caucus had a telephone call with some of the people who were involved in making the decisions. I offered to say, hey, I've had the vaccines. Could I donate plasma for use for someone, since we're running out of monoclonal antibodies? And I was told no, because it's people who have had the disease that have the type of antibody robustness that we need for convalescent plasma. So you, as someone who's just received the vaccine, are not, that's not going to be a suitable source. So that told me that there's really more work we need to do here. And then for whatever reason, it just wasn't pursued. And the mandates, which I deeply felt were not going to be a mechanism to get people to show up to be vaccinated. If there was hesitancy, you're probably not going to overcome that hesitancy with a federal directive. It's more show, don't tell. So that got us into a tough place on people, whether they're going to be vaccinated or not, and people lost their jobs. And now we've got, airline employees who were laid off and air traffic controllers who were laid off because they wouldn't conform to the mandates. And I don't know, has anybody flown lately? That's a nightmare too. You'd think we were over the pandemic and you wouldn't be scared to go to the airport anymore. Now I'm scared because I'm going to be stuck there for 13 hours before I leave.
I used to cover healthcare in 2003. The Republicans passed the biggest expansion of Medicare. In 1998, the Balanced Budget Act made major changes to Medicare. Medicare right now is on a track that's not sustainable. When are policymakers going to have to address this? Because the system is going bankrupt and no one seems to be talking about it.
Well, I like to talk about it.
Okay, all right, let's talk about it. I mean, because that's something the former President Trump didn't want. He didn't want Medicare reform like Paul Ryan did and some others. But what do you think is going forward? I mean, it's not sustainable.
Yeah, so something will have to happen. Just like Social Security, when the trust fund gets exhausted, yes, there are decisions that are going to have to be made. And my thesis is we ought to rationally approach those problems, do the hard work in committees and our authorizing committees, and come up with a way forward. And for me, of course, coming at this as someone who practiced medicine for several years, I feel with great intensity the discomfort that is voiced to me by physicians across the country who say the physician's fee schedule as proposed by Secretary Becerra is going to drive us further out of business. As you know, I spent my first 13 years here trying to repeal the sustainable growth rate formula because I thought it was unfair to physicians. Problem is that things that have evolved since then have been no less injurious. And then the tough part is we came through the pandemic and we said, oh, doctors, nurses, you're our heroes. We sing songs to you at night. We laud you from the floor of the House. And, oh, by the way, here's your pay cut. And they went, wait, what? Why am I getting a pay cut for being your hero? And so if nothing else, just focusing on the physician's fee schedule, which I think if we will do that with hearings and collecting information and entertaining offsets and the types of things we would have to do on an authorizing committee, I think that will lead the way toward what perhaps is some fundamental reform that people could live with. Thank you for pointing out that I was part of the Congress that corrected the problem with leaving prescription drugs out of the coverage of Medicare. Yep. So President Bush, tip of the hat to you for fixing that problem. Medicare Advantage occurred.
That wasn't easy. 15-minute vote was a 3-hour vote. I was there that night.
We've surpassed that since then.
Yeah, exactly. No, it has been surpassed, yeah. I did want to ask, we have just about a minute left, with COVID, I had never done a telehealth appointment before, and now I've done several. I'm sure everyone has here. What's the future of telehealth in the wake of COVID?
Well, telehealth, as you know, is existing right now under waivers that were granted by HHS because of the public health emergency. no one thinks it's going to be acceptable to go back to the status quo. Now, there's a bill that was in the Rules Committee yesterday, will be on the floor of the House to extend for 2 years, statutorily extend for 2 years the waivers that have been granted. So that's a good idea, but we really ought to just fix it. I was extremely grateful when it's not just telehealth with a computer screen, but even a telephonic conversation can now be a covered event. I spent a lot of time on the telephone after hours when I was in practice, and I used to fantasize about getting paid for those phone calls. Now apparently you
can get paid.
So that's a good thing. But patients aren't going to go back. I mean, regardless of what legislators do, regardless of even what physicians do, patients are going to demand that this improvement not go away, and no one's advocating to go back to the status quo before the COVID.
And the bill in the Rules Committee, is that going to pass easily? Has it got support from both sides, or no?
Like anything else, it gets gummed up with some other issues.
Yeah.
But my expectation is that you will see that pass this week. I don't know what the Senate likelihood is.
Mm-hmm. Well, we've run out of time. Please thank Congressman Burgess for joining us this morning.
Thank you.
Hey,
thanks
so
Bob.
much.
Well, I wanted to thank Dr. Burgess. Always great to hear him, and always learn a little bit more when he has an opportunity to talk. So good morning, and I want to thank you all for being here, for being part of this conversation. Over the past 2 years, navigating the public health crisis, patients are abundantly aware of the hurdles that they face in getting health care. Level ground, I believe, is a fitting title for today's conversation because it's exactly what is needed in order to assure equity in the healthcare marketplace. My name is Bob Dold, and I'm here today on behalf of AIR 340B. It's a coalition of patient advocacy groups, clinical care providers, and biopharmaceutical innovators. As a former member of Congress, I've spent tons of time outside of Washington, D.C., visiting with patients, with hospitals, and those that need government services. Patients who count on those services to work as they were originally intended by the United States Congress. The 340B program was built to support low-income and vulnerable patients through a system of safety net healthcare facilities in medically underserved areas of our nation. Unfortunately, the vast majority of those hospitals, their child sites, and affiliated contract pharmacies are located not in those areas, but in affluent areas, rather than in the communities that need them the most. Our coalition advocates for fixes to the 340B program that ensure that it works for patients. And the majority of voters agree with that sentiment. Hospitals and pharmacies should not be profiting off of safety net programs intended to help the low-income and vulnerable patients of our nation. The 340B program can play an important role in advancing health equity. But I believe that we need to reconsider the eligibility standards for the medical facilities that participate in the 340B program. That, coupled with increased transparency and oversight, will help prevent further abuse from hospitals and pharmacies. In fact, just today, we're launching a new tool, an explainer of sorts, to help Congress and policymakers better understand the issue, because that's what we need. We need them to understand the issue that we face today and how important it is for America's patients. So here is a preview for you to view.
How can we better advance health equity? Improving an existing safety net program called 340B is one critical step. 340B was created to help low-income and uninsured patients access life-saving medicines. Through the program, manufacturers provide medicines at significantly discounted prices to participating hospitals and clinics to help them provide medicines to vulnerable patients. However, a recent report on 340B and health equity finds the majority of 340B disproportionate share hospitals, or DSH, their child sites, and affiliated pharmacies are not located in medically underserved areas. These are areas that most need improved access to care for vulnerable populations, like communities that have too few primary care providers, high infant mortality, high poverty, or a high elderly population. Only 38% of 340B DISH hospitals and less than a third of their child sites and pharmacies are located in these MUAs. This is a missed opportunity for 340B, a federal safety net program, to truly advance health equity so everyone has the opportunity to attain his or her full health potential, regardless of socioeconomic status or circumstances. Policymakers need to hold those utilizing the 340B program accountable to ensure only true safety net facilities serving vulnerable communities can participate. This would help restore 340B to its original purpose and target the billions of dollars in discounts to directly help low-income and vulnerable patients access their medications, instead of lining the pockets of hospitals, for-profit pharmacies, and other healthcare facilities. Learn more at 340breform.org.
So I want to thank you all for being part of today's conversation and helping advance the issue of health equity. And I also want to offer, if you have other issues, questions, concerns that we can answer, please reach out to the AIR 340B Coalition. Thanks so much for being here.
Thank you, Congressman Dold and AIR 340B, for your support of today's conversations. And now, please welcome our panelists in conversation again with Bob Cusack, Editor-in-Chief of The Hill, Dr. Elena Rios, President and CEO of the National Hispanic Medical Association, Avik Roy, President of the Foundation for Research on Equal Opportunity, Dr. Gary Puckrin, Founding President and CEO of the National Minority Quality Forum, and joining us virtually from Baltimore, Dr. Lena Wen, Emergency Room Physician and Professor of Health Policy and Management at the George Washington University.
Thanks, and thanks for joining us, panelists. Lena Wen, see you on TV all the time, so now looking at another screen. I'm gonna start with you. What on specifically access to care? What have we learned from the COVID-19 pandemic?
Well, first of all, wonderful to join you all today. I'm sorry that I can't be there with you in person, as I actually have my childcare this morning and unfortunately have to get to clinic immediately after this. So I think we've learned a lot from COVID about access. And I think we've seen how disparities are not new to COVID, but certainly were unveiled and unmasked during the pandemic. But I actually also just wanted to share some thoughts about the issue of access from my experience as a practicing clinician here. I work, one of my clinical sites is here in Baltimore for a clinic for underinsured and uninsured patients. And when we think about access, I think initially there's a focus on cost, which absolutely we need to talk about the cost of prescription drugs. We need to talk about the cost of healthcare, the cost of insurance, and so forth. But I think we also have to consider the other conditions in people's lives. I mean, so many of the patients I see, especially when it comes to chronic medical issues, for them, health is not at the top of their priority list because they have so much else that is going on in their lives. They're managing their children, their grandchildren, their parents, they're working multiple jobs. And a lot of times they may be running out of medications or not filling their meds, or not even knowing that they have run out, simply because there are so many other issues that are at the top of their attention list, and they have not gotten to the issues pertaining to chronic illnesses in particular. And so I think closely related to this is the issue of addiction and mental health, that individuals with behavioral health concerns are not getting those attended to, and those issues then further exacerbate underlying physical health disparities as well. And so I hope that we'll be able to discuss all of these issues in some way today, understanding that as you were saying in your question, that COVID certainly unmasked and helped us to see some of these disparities firsthand, but they have existed well before and are going to exist well after the state of emergency around COVID ends.
Dr. Rios, as far as one thing, healthcare is such a vast field, but what do you think policymakers, whether it's federal or state, need to invest more or focus on more that they're really not focusing on now?
Well, I think when the Affordable Care Act was passed, part of the Affordable Care Act that needs to be discussed again is public health. And public health the infrastructure as well as the ability to use a public health system that works to get to the community. So in our community, in the Latino community, most people aren't insured. There's still a large group of people, whether they're poor and work for small employers or are immigrants, what you name it, there's a lot of people that don't have insurance, which means they don't have the, let's say, they just don't think about going to the doctor unless they have an emergency. And so for us, healthcare information and education needs to go through public health or needs to go to the community. With the churches, with the grocery stores, with the institutions in our communities where people can get information. And I think that's something that needs to be discussed again, and as well as what Dr. Wen said about mental health. It's so important that we have so much mental health issues because of chronic stress, because of not only chronic diseases, but the issue of the social determinants in our communities. We have drive-by shootings, gangs, people that are accosted just walking down the street, can't even walk safe in some of our neighborhoods. And I think that causes more anxiety and toxic stress in our families. So there's just so much that needs to be done.
Looking at COVID has been such a difficult time for so many people. I think we all know people who've lost their lives from COVID. But it seems like one silver lining, and you mentioned mental health, so I wanted to follow up on that, is people seem to be more open to talk about mental health issues. Is that one of the silver linings you see, and do you think that'll continue? Because it still is a stigma, but I think it's less of a stigma than it used to be.
I have to agree that people want to get more care, but where do they go for care? We need more training of younger people with, let's say, connected to STEM. The Department of Education always focuses on K through 12 and doesn't think about careers. HRSA gives money to the medical schools, to only the few that get into medical school. So there's got to be a connection between education and career development for the STEM students in our country that are science and math, that have science and math abilities to be able to go on into medical school and get into psychiatry, or to become social workers. You don't have to be STEM, but to become social workers and professionals to deal with the problems in our communities, I think is important that we do that.
Avik Roy, I want to talk about health equity and the healthcare system we have now. You would not devise, but we are where we are. I remember when I covered healthcare, Ways and Means Chairman at the time, Bill Thomas, floated the idea of decoupling employment and healthcare coverage because it just doesn't really make sense. You lose your job, you lose your healthcare. But that was very politically difficult to do and was not done. And so it comes down to, when you're talking about health equity, you're talking about the price of healthcare. Where are we and where are we going on health equity?
Well, Bob, thank you for asking that question. First, I want to talk about this COVID piece just for a minute, because I think one thing that we have not yet learned or not yet fully appreciated about our experience with COVID is how much our response to COVID worsened disparities. So when you have economic restrictions that people like us who work off our laptops have no problem with, but people who work with their hands, a bartender, an assembly line worker, they're the ones who face the consequences of that. The school closures, which were not necessary, or could have been adjusted a lot better to balance public safety and education for kids. Now, all of a sudden, oh gosh, there's all these learning losses that we now have to contend with. We knew this all the way through. Other countries had reopened schools and safely done so. We didn't learn those lessons until it was much too late. So I think we're only now beginning to contend with the disparities that our response to COVID created that are really important for us to focus on over the next several years. Now, you mentioned a great point, which is that not only is our healthcare system obviously inherently regressive in certain ways, but the most important and most regressive piece of it has to do with the tax code. It's the fact that we've excluded from taxation employer-sponsored insurance benefits, group insurance, which has driven all sorts of inflation, as everyone who does healthcare for a living knows. And I think one thing that there's a ray of light in this area. So it's been a very hard thing to reform, as we've all known, particularly those who've worked in Congress. But there's a ray of light, which is that there's this new rule that came out of the Trump administration that allows health reimbursement accounts to be deployed to purchase individual insurance. So it used to be the only way you could take advantage of the tax benefit from employer-sponsored coverage is if your employer bought the coverage for you and for your entire group. Now there's an opportunity for employers to say, you know what, we're going to give you $5,000, $10,000, whatever the employer wants to give, in a health reimbursement account that's also tax-free, but that allows you to shop for the coverage that you want on the ACA exchanges. And so that is a model paired with other reforms that strengthen and build on the exchanges, could over time really allow for that individual choice so that people aren't just handed a piece of paper from their employer, but actually have multiple options. And that's profound because it incentivizes the insurers to compete for workers' business. Say, you know what, I'm going to take a tougher line with the hospitals. I'm going to take a tougher line with the drug companies so that you have a lower premium, so you choose my insurance plan. And that creates a lot of downstream benefits that we're not seeing today because the patient, the consumer, is a total passive participant in this process.
Gary, National Minority Quality Forum has some new poll findings out this morning. Can you tell us a little bit about it?
I certainly will, but before I just talk about the poll, I want to help us reset this conversation a little bit, right? Because I don't think we're always being honest with ourselves when we're talking about healthcare. We're always about healthcare for ourselves, right? I don't think anybody in this room would go into a healthcare system with the expectation that they're not going to get optimum care out of that healthcare. So the conversation is really about healthcare for our neighbor. What we're arguing about is whether I want to provide healthcare for our neighbor. And the point of the matter is that in this democracy, we promise collectively to work together. In fact, it's life, liberty, and the pursuit of happiness, life being the first one. And so I think if we start with an honest conversation about, I'm really having a conversation about the access to healthcare that I'd like my neighbor to have, because I know what I want, right? But I want to talk about what my neighbor has. And the minute you do that, you come to the question of, do we actually value life? Do we actually value our neighbor's life, right? Because if you don't give access to health care, you are putting that life at risk, right? You may go through your legislator or whoever, the proxy that you have, but the point of the matter is you've made the decision that the life of your neighbor is less valuable to you. And so when we have these conversations about access, about drug pricing, all of those conversations are really about what would I like my neighbor to have. Unfortunately for the African American community and Hispanic community, because we quote unquote have been minorities in the population, the majority has in effect said that we're going to limit access to health care for you. And that's what disparities are about. They're about the fact that the healthcare system is denying access to quality healthcare. And you can look at the numbers. We don't have to have an argument about fact because the facts are very, very clear that they're not getting access to quality healthcare. And so we started to reach out to the minority community through polls, and we'd love to continue to do that because their voice needs to be heard in this conversation, right? Because it is a collaborative. Healthcare is a deep collaborative. And when we go and we talk to minority populations about things like drug prices and other things, it's not a monolith, right? There are some who support government interventions, and there are some who do not. But from the NMQF perspective, from the National Minority Communities perspective, we have to provide optimum health care to everyone who comes through the door. We cannot give ourselves permission to deny quality health care to anyone, right? Because that invalidates the collective promise that we made to each other when we formed this government, that we would take care of each other. And healthcare is definitely a part of that. So what you're going to see in the polls that we're putting forward is that you're going to hear the voice of minorities for the first time because they have not had access to things like polls that actually tell you what they're thinking and feeling about healthcare. But at the end of the day, we cannot give ourselves permission to deny our neighbor access to quality health care. That is a complete violation of our commitment to each other.
And the poll.
Mm-hmm. And the poll.
What did your poll find?
Our poll find that minority populations, African Americans and Hispanics, are concerned about government setting prices, right? In no place else in our economy, no place any place, do we think it's a good idea for government to set prices? And there's a whole historic reason for that. If you go back to the Nixon administration, right? The Nixon administration tried to set prices, and it led to stagflation, right? Because the marketplace reacts to the fact of government setting prices. And the other point that was being made here that's incredibly important is that the healthcare system has to be consumer facing. It can't be government facing because government becomes the client in that instance. What we want is a healthcare system that's valuing every life when it wakes up in the morning and is concerned about reacting to that consumer. And the only way that can happen is that it has to be consumer facing. And you cannot have a healthcare system, I would argue, that is going to deliver quality care if government is going to set value. And that's what pricing is. It's government setting value, and that's really not a good idea.
I would love to say a couple things in response to that. First, I think broadly, it's not just minorities who want every American to have access to good health care. I think all Americans want that. Polls show overwhelmingly that the overwhelming majority of Americans want a system in which everybody has a fair shot at good access to health care, the basic financial security. We all want that. We may disagree about how to achieve it. There's obviously a lot of blockers to make it possible, but I think that's a widely held aspiration. It's not just a minority aspiration. That's number one. Number two, on the point of prices, it's ideally you'd have a system in which people, just like in the rest of the economy, compete for your business, and that's how prices are set. But in parts of the country where, say, there's like in Connecticut, where I went to medical school, Yale New Haven Hospital Health System owns the entire state. There is no competition, right? So in many parts of the country, there's become massive consolidation with hospitals. In drugs, there's not monopolies just because of patents, but also because of other things that Congress and the FDA have done to create artificial monopolies. When you have a monopoly, you can't have the competition. So then what do you do? And I think that's a tougher problem for just let the market figure it out idea. You either have to create the competition, which I would certainly prefer as a free market advocate, or you have to do something to regulate monopoly exploitation of their status.
I'm all about competition. That's the American way. We compete in the marketplace every day. I think that's a great idea. And the challenge has been, when government came into the marketplace in healthcare in 1965, it promised that it wasn't going to set prices. If you go back and listen to that conversation that went on in Congress and with President Johnson, the idea was government was not going to come in and set prices, that it was going to let the marketplace compete. I'm for competition. Right? Now, obviously, it's not a free-for-all competition. You have to set boundaries for sure, and government should be that referee, setting boundaries, but it shouldn't get on the field and play baseball, right? It shouldn't be down there on the field, calling balls and strikes, batting, pitching. I mean, that doesn't work. So I think good competition in the marketplace is a great idea, and we want to figure out how to free up the market in healthcare so it works.
Lena Wen, I want to get your opinion on monkeypox, which is such a huge issue, and especially in D.C., the highest per capita rate now across the country. Where are we and where are we going? It just seems like the news keeps getting worse.
Well, I just wrote a column in today's Post about this, and I think there are two things that are simultaneously true. One is that most Americans do not need to worry about monkeypox yet, as in this is not something that people should think about changing their daily lives or rushing out to try to get a vaccine. Most people, obviously there are some who are particularly vulnerable. If you're in the community of gay, bisexual men who have sex with men, with multiple or anonymous sex partners, a very different story. This is the population most at risk. But most people don't have to change their lives yet. At the same time, there needs to be a public health response, because for us to turn a blind eye to monkeypox and think that it's something that's going to stay within one population or will not affect us in the future, I hope we've learned by now that infectious illnesses don't stay in one group. And in fact, that this is a threat that really needs to be contained. And I think it would say a lot about our lack of a public health system if we're unable to contain this, given that we have known about monkeypox for decades. This is not like COVID, which was a very rapidly spreading novel coronavirus, respiratory virus, spreading easily from person to person. Monkeypox is spread through direct, prolonged, intimate contact with someone. There's also a vaccine that's already available that can be given to people after exposure to prevent them from developing the illness. And so there's every opportunity for us to contain monkeypox. And I think these two things can both be true at the same time, that most individuals do not need to yet worry about monkeypox, yet health officials need to do a lot more. And from that standpoint, yes, we need to get more vaccines out. I think we also have to focus on testing, because if it's anything that we've learned from COVID as well, it's that if we don't test, we're not counting cases. And I suspect that there are a lot more cases that we're not yet testing for. We don't yet know the degree of asymptomatic transmission that may or may not be occurring. And we have to do a lot more in terms of reaching out to individuals and identifying them so that we can break the chains of transmission.
Dr. Rios, I wanted to ask you about telehealth as far as access to care. I was talking to Dr. Burgess before from Texas, and he says we're not going back. Mentioned pending legislation on this. Now, at the same time, not everybody has high-speed internet across the country.
Right.
So is that something that has been, you think should continue? And what are the other obstacles that you see, outside the Beltway that maybe Beltway people need to focus on?
I think we are going to have to continue telehealth, and I did appreciate the Congressman's support for continuing, the laws that are being discussed right now for the next 2 years, and to actually make it more standardized. But I do think that communication with people that do not have access to internet is going to be important. Most people have a cell phone, and texting has been shown. The HRSA's maternal child health programs have used texting for a long time, and I think that that has to be included too, not just a video screen, computer, intranet.
Mm-hmm. Avik, as you've advised Republican presidential candidates. I was talking to Congressman Burgess about the likelihood the House is going to flip, the Senate is kind of more of a jump ball. But regardless, what should be the Republican agenda in 2023 if they have the House and/or Senate?
There's actually a comprehensive health reform bill that a number of Republicans have introduced, both in the House and the Senate, called the Fair Care Act, that strives to achieve universal coverage using private insurance. Obviously, the public system is still there, but it fills in a lot of the gaps and tries to tackle the cost problem in both, particularly hospital care and drug pricing, and does a really nice job of means testing. The way we help people afford health insurance right now, as we talked about earlier, we have this employer-based system in which you get a bigger tax benefit if you're in a higher tax bracket. So you're wealthier, you're a lawyer, you're an investment banker, you get a bigger subsidy from the government to buy health insurance. The Fair Care Act would fix that, so you get a standard deduction and use the savings to help fill in some of those gaps in health insurance and the uninsured population. So it's a very interesting bill. I think what's happened is that because Democrats have had the House and the Senate and the White House, there hasn't really been an incentive to work with Republicans, right? The incentive has been more, let's just do what we can do on our own and leave the Republicans out of it, which, I understand that as a political point of view. But if Republicans control one or both of the houses of Congress, then it becomes there becomes a bigger opportunity to try to build bridges, right? To work on some of the other ideas that may have bipartisan support. So I think that, to me, is the opportunity. Now, there is, of course, the various task forces that Kevin McCarthy has set up, and including one on health care. To me, the what they're working on that front is relatively like the low-hanging fruit, things that aren't going to put a target on their backs and jeopardize their ability to win in November. Which, again, I understand from a political standpoint, but my hope is, and certainly what I'm advocating for is, once you get through November, whatever the result is, let's find ways to work together and solve some of these big problems. They can increase health equity, but also solve the sustainability problem of our healthcare system. Because at the end of the day, I have young children. We're not going to have a healthcare system if we keep going the way we're going with a $30 trillion, $50 trillion, $70 trillion debt in the future.
As you know, politically, if the House does flip, you're going to have freshman members who are going to want to vote on repealing Obamacare. If you had a magic wand, should that fight be over now? The Supreme Court has spoken, or obviously Joe Biden is not going to sign any bill into law, so it's going to be divided government. Do you think Republicans should move on from that, or are they going to have to do it politically because the new majority members will want to vote on it?
I actually think it's the exact opposite. In my experience, the experience of our team, the people who are the most interested in moving on from the fights of the 2010s and actually solving some of these big problems of affordability and uninsurance are the freshmen, are the younger members who are not tied into the battles of the past and actually say, you know what, I came to Congress to solve problems. My constituents can't afford their health insurance. Their deductibles are going up. Their premiums are going up. They're struggling. It's inflation in general is a problem in this country, but healthcare inflation has been a problem for a very long time. That's not a new phenomenon. And these members know that. And so I think what you're seeing is a real opportunity or a real window where a lot of these new Republican members saying, hey, I want to tackle costs. Take Jim Banks. So Jim Banks is a third or fourth term congressman from Indiana, heads the Republican Study Committee, which is the most important Republican conservative caucus in the House. He has sponsored the Hospital Competition Act based on a lot of our work at FREOP on hospital competition, which really does an effective job at trying to tackle a lot of these problems around the anti-competitive practices of consolidated hospital systems. So there is a lot of leadership coming out of these younger members that I think you'll continue to see in November, after November.
Gary, I want to close with you as far as programs that maybe work at the local level or state programs that you think federal policymakers should look at, because the states have their own healthcare systems and Medicaid, and it's kind of a alphabet soup of government agencies running them. But if you had a kind of a magic wand, what do you think should be a model for healthcare moving forward?
Well, that is one huge question, right? And so you have to figure out which part of that elephant do you want to bite on. I think where I would start really, so Medicare is a disaster. Let's all agree to that. We've got 90 million Americans in a healthcare system that is a prisoner to state budgets. And somehow we've got to fix that monster because they're not going to get quality healthcare. But from a clinical standpoint, if I'm just thinking clinically, how do I want to improve the health of the American population? I would start with data. We have to unlock health data in this country. We can get very, very smart very, very quickly. COVID taught us that we can build the plane and fly it simultaneously, meaning we should be able to tackle diabetes as a national emergency, right? This is a raging epidemic in our country. And we could use the methodologies that we developed with COVID, where we find innovative therapies and we figure out how to get them to the American population as quickly as possible. There's tremendous work going on in cancer with these liquid biopsies that are coming on, that are diagnosing 50 cancers at one time and finding people who have cancer before they're symptomatic. Think about that. Before you're symptomatic, we'll be able to treat you for cancer. What's broken is our healthcare financing system. It is archaic, right? It is a complete broken mess. And so I would start building that data system so we can move the data, and then we've got to sit down around the table and have a real conversation about healthcare financing because we are not going to take advantage of all that wonderful innovation that's available to us in the current system. It's just not going to work.
We have run out of time. I want to thank our panelists, Gary Puckman, founding president and CEO of National Minority Equality Forum, Dr. Elena Rios, President and CEO of the National Hispanic Medical Association, Avik Roy, President of the Foundation for Research on Equal Opportunity, and Dr. Lena Wen, Emergency Physician and Professor, Health Policy and Management at George Washington University. That brings us to the end of our program. On behalf of The Hill and our sponsor, AIR 340B, we'd like to thank everyone who joined us here today. And if you missed any portion of today's discussion, the full video will be available on thehill.com. Thank you so much. Appreciate you joining us today.
Great.
Thanks, Bob.
Thank you.
Thank you.
Great.